Hello, my name is Robert Pollock, and this is the Evaluational Reflection 2 over a shoulder evaluation that I did last week. So, some background on this case. The patient had been reporting she just felt tightness in her shoulder and she just wanted heat. She didn't want anybody to look at it. It was fine. We tried. She liked to use Graston, so we tried Graston. We did heat to try and just loosen everything up. So on Monday of last week, she came in and we did an evaluation on her, and I got to lead it, and basically what she was complaining of was muscular soreness, tightness, and pain associated with that tightness. So some of the things we did that I did in the evaluation was palpate the SC joint, the clavicle, the AC joint, scapula, thoracic joint, just to see, like, is anything there causing this anterior shoulder pain that she's complaining of. None of it did, and but when I palpated anterior glenohumeral around the coracoid process, it was positive for pain. So with that, it kind of led me going down, making sure, just to make sure that rotator cuff, labrum was intact, and going through all of it, everything major was fine. There was no labral tear. Rotator cuff was still strong, but had some pain, but not a significant amount of pain. It was more of a soreness, like a tightness type feel. So doing all that, I took goniometric measurements for flexion and abduction. It was different because it was like the first time that I actually used a goniometer to do range of motion, and I actually really liked it because it gave me solid measurements for this is how much you're decreased. And the patient was 164 and 134 in flexion from unaffected to affected, so a 30-degree decrease in range of motion is significant. And in abduction, they were about 13 degrees, 180 to 160, 180 to 167. So again, pretty significant decrease in that, and a lot of pain experience with abduction. So going on from that, I thought for sure it was going to be rotator cuff or labrum. She had been swinging a lot, experienced the pain with swinging, decrease in performance with swinging, all the stuff. She just felt weaker, felt it was becoming more and more painful, and she complained of shoulder pain right in this general area. She didn't really point here, she went, it's kind of here. So thought for sure it was going to be a labrum. Went through it, did all labral special tests. None of them were positive. So from there I went to, maybe I looked at, before coming to the conclusion of labrum, I looked at her range of motion just actively with no measurements, and she experienced pain in the painful arc. So thought, okay, maybe it's an impingement. So I did Hawkins Kennedy, and that was truly positive. She was in a lot of pain when doing that. And then also looked at Neer's impingement, and in Neer's she was also positive. There was a lot of pain experience with that. So before giving her what I thought it was, I talked to Emma, and Emma helped me finish the evaluation. So one of the things that she did that I neglected to do was have her remove her shirt. So when the patient removed her shirt and I did the observation on flexion and abduction, it was very apparent that she had scapular dyskinesis. Her right scap was moving way faster than her left one was. or when it was coming down, it was moving way slower than her left one was. So knowing that bit of information, we decided that it was, yes, impingement, but it was probably secondary to her scapular dyskinesis, or the instability in the scapula. So we got together in clinicals the next day and talked about the case, and one of the things she offered me was definitely to make sure with any patient, if you want to assess scapular thoracic rhythm, you need to have them remove their shirt, just because that was a pretty key example. I completely missed that she definitely had scapular dyskinesis. One was moving faster than the other. They were not at the same. Another thing she offered me for the shoulder is that to include a patient-rated outcome measure. So with the shoulder, it's pretty muddy with diagnosis. There's a lot of things it could be and not a lot of things you can do that are effective based on evidence-based practice. However, with the inclusion of a patient-rated outcome measure that asks about 50 questions, or however many questions the one you select does, it gets answers to information, and gets you answers and information on things that you necessarily might not have thought of during the evaluation. So one of the things that we talked about was just to get used to installing a patient-rated outcome measure is every time this athlete comes in for her shoulder or whatever, use the global rating of change. Ask them, okay, I want you to go read that paper over there. Tell me what number it is on the global rating of change scale. And I got to do that this past week and the week before with her rehab, and it was great. It does a lot. It gives me a lot more information than, oh, I got better, or no, not really. It actually quantifies and gives you next to the numbers what that means. So if someone's a -7, it got a whole lot worse after treatment. And if someone's a +7, it means got a whole lot better, they're ready to go play. It's a great tool for rehab and evaluation in general, and I've actually taken a picture of it and put it on my phone so that the next clinical site I'm at, if I don't have it with me, I can use it and be like, okay, hey, can you look at this? What would you say you're at? Similarly, I've downloaded some of the patient-rated outcomes onto my computer, because I know I'll probably bring my computer to whatever clinical site I'm at, and if a patient walks in with a knee, I have the COOS ready, and if a patient walks in with ankle, I have the FAAM ready for them. Just, hey, can you sit down, just take this real quick, it'll be about 10 minutes. It'll just help me out and help you out with your evaluation. The other thing that we talked about was the palpation. It's okay to be a little bit forceful, palpate with a purpose, especially with musculature. So when I was palpating the musculature, I felt knots, but knots and adhesions, but it was kind of muddy. And one thing we talked about is that it's okay to get in there and palpate and find those knots. And will the patient be in pain? Yeah, probably, but it will help you when you do your if you perform Graston, or if you are doing a trigger point release or muscle stripping. It's going to help you so that you can find that spot earlier and know what their spot is to release it. So with that, some of the things that I've included in an improvement plan for my evaluations on shoulders are definitely making sure that I have that patient remove their shirt and watch their scapulothoracic rhythm. It'll give me a whole lot more information than what I have, and it'll give me a better idea of what's going on. That downloading of the the global rating of change on my phone, and then the downloading of other patient-rated outcome measures on my laptop so that patients can utilize that so that I have a better information set when I do my evaluation is another thing that definitely I've been using. And the final thing is that making sure that I palpate the muscles with a purpose to find if there are trigger points or if it's tighter than the other. It's one of those bony structures, there's an obvious deformity if something's broke. Muscular structures sometimes are harder, and getting used to palpating the muscular structures and feeling in there to see what a normal feels like and what their inflames feel like is going to help me with my evaluation process. That concludes the evaluation reflection of the shoulder patient that I had. I hope to keep doing the improvement plan and keep getting better with my evaluation process throughout the rest of the semester. That's all. Bye.